that works so easily. Awesome. Okay, well, let's go ahead and get started because we're going to try to pack in a ton of information into just, I think we have 90 minutes together. I'm going to try and kind of buzz through, but there's a lot of really key talking points today. So I'm going to try to leave enough time for some questions at the end. Marcy, do you have anything that you need to cover before we get started, or should we just dig right in?
I think we can just dig right in. Just welcome everybody. And if you can just keep yourself on mute so that we don't get background noise, that will be great. Thank you.
Terrific, terrific. So great to be with you all again. Just to remind you, my name is Megan McKinney Todd. I am the Executive Director for Good Life University, which is the education and dissemination arm that's related to Good Life Innovations. And co-presenting with me today is Good Life's President and CEO, Dr. Mike Strauss. Hey, Mike.
Hey, everybody. I will be adding the color commentary today.
Yeah, so he's got my back. He's done this presentation a lot more than I have, but we have worked together to really extend and expand our training, especially as it relates to technology, enabling technologies, and the use of remote supports, especially in human services. So we're going to dig right in. Just to kind of, I like to give a little bit of background in case you didn't join us before. So Good Life University is the applied research partnership that Good Life has with the University of Kansas Department of Applied Behavioral Science. And we have had this process and this partnership that's related to a process of continuous improvement for nearly a half century. So 50 years, we've had this incredible partnership. And so just to help you understand the mission of the organization and Good Life University is to really disseminate research-based best practices that meaningfully improve the quality of life for the individuals we serve, but also their caregivers. And that's a really important distinction that we made by adding to and expanding our mission about 10 years ago. So with that, what Good Life University offers overall is consulting on workforce, which we talked about last time. We also deliver technical assistance and change management support. The Performance Management Center for Good Life is housed within the Good Life University umbrella. And then we're also working on service model development and dissemination, which are related to the Neighborhood Network and iLink Technologies, both of which I'm going to introduce you to today. So one thing to just know as an overview is that every practice solution technology that Good Life University disseminates or helps other providers with has first gone through a pretty extensive process within the Good Life organization itself as a beta site where we're creating, using, measuring, assessing, refining, and then replicating what we've got. So we're never really taking something and sharing it with others unless it's something we have done and done really well for a long time and backed with a lot of research and evidence-based practices. And again, that is really made possible because of our relationship with the University of Kansas, the Department of Applied Behavioral Science. So today we're going to cover Technology 101. I'm going to talk first about why our workforce is disappearing and why it won't come back. This is going to be we're going to buzz through it. I'm hoping that you were able to join us in our last session, which really dug into the workforce problem. Then we'd like to do a barrier analysis and help us understand essentially why congregate care persists for care delivery models for so many populations when it's not preferred and not safe. And then we'll talk through the solution. So our next generation of care solution is really developed by the lessons that we've learned from other industries. And we're going to talk through how it was built, what the foundation and the principles of that solution are. Then let's chat about the characteristics of a strong technology partner. So let's just assume you're going to say yes to embracing technology in your human service models, but now what? This will help give some guiding principles, I think, for how you should be evaluating the technology partners that you seek out, and hopefully that you guys will be able to work together to really promote next generation practices. Then we've got a case study and some impact measures to share with you. And before we sign off, I just want to make sure we touch on some policy, regulations, and funding implications. So here we go. Our workforce is disappearing and it won't come back. So why is this? I think I said this on the first session, the workforce crisis is not new. We have been consistently in crisis for decades, but I do think that COVID kind of created a supernova event, and more than ever, we're seeing some really, really significant indicators in the market that we think are gonna, that mean essentially that the workforce crisis is here to stay. So that doesn't mean we need to keep bailing water and keep going, trudging along as we always have. What it does mean is that we need new innovations and solutions to really allow for the next iteration and the next several years to be thriving years instead of just surviving years. We know what surviving feels like. So some of the reasons why the workforce is shifting so much and why it's hard to feel stable with a workforce is because remote jobs are on the rise. 65% of job seekers choose that as their first priority. And you know very well that delivering care is not a remote job. We've also seen that wonky and fractured schedules are still really pervasive, especially in human services and specifically disability services. We've recognized too that the needs for the individuals that we're caring for are challenging and diverse. With an IDD system that's in rapid transition into the final rule, which we're going to talk about a lot more, there's additional challenges for regulatory challenges and sort of compliance challenges that are new. And all of this is kind of happening on one side when we've got baby boomer population going crazy. So every day, 10,000 seniors are turning 65. That's 1 every 8 seconds. We're essentially expecting to double the number of seniors in America between now and the year of 2060. And that exponential rise in need really is going to compete, and already has, with the IDD industry. You know that funding rates in IDD are less than ideal, and realistically, we're not going to be able to keep up with the what we're calling gray pay, which is essentially the rates that are associated with the senior market, because 70% of them are private pay. And then I'm going to add that the working conditions, in addition to the complexities of the individuals served, working conditions for our direct support professionals are really challenging, and we're asking them to navigate those challenging situations often and increasingly alone in order to meet the final settings rule. So let's talk about that for just a little bit. Increasingly complex matters in homes where DSPs are working alone. You'll hear me interchange DSP, DCW. Essentially what I'm referring to here is a direct care worker, DCW, or direct support professional, DSP. But they're all, essentially what we mean are the caregivers, the boots on the ground that are delivering in the moment support to enable people to live in the community through primarily home and community-based services. And we're not talking just about IDD though. This really can and should be considered for most Medicaid services. And a lot of the principles that we're talking about can really have that interdisciplinary application. So okay, but 40% of the people with IDD also have mental health needs. That makes things really complicated. There's medications and medication management and med passes that are increasingly complicated. You've got substance use and abuse that's growing within IDD. That's a growing challenge, actually. We're also seeing that people with disabilities are living longer, even when they have chronic illnesses. Lifespans are extending, and we're very likely experiencing an aging of our intellectual and developmental disability population that we have not seen before because of advances in medicine. That means, though, that their lives are still very challenging, and that the individuals supporting them in their homes need to have a certain level of medical or direct support experience in order to be successful. So overall, the health outcomes for this population are worse than the general population. And so because these complex needs are sort of evolving and revolving around the individuals that are now able to access community-based services, the support that's needed for the direct care workers who are increasingly on their own is really important. And this is all in the sort of the brackets in the context of CMS's final rule. And we know that there's a shift at the federal level that may put a little bit less emphasis on the final rule compliance or regulatory standards, but ultimately this is not going away, and nor should it. We all really agree with the vision that the final rule cast, which is for people to live in small, inclusive homes in typical communities and in typical neighborhoods. They want those community-focused lives, individualized supports, and of course, our goal is to be advancing independence, choice, autonomy, rights, essentially developing and empowering a very enriched and full life, regardless of one's ability. So again, we see this really important because of COVID, but it definitely has challenging implications for the caregiving workforce. And so I want to talk about those things real quickly. Here are the challenges. So we're recognizing that the need for system transformation is really, we're not keeping pace. And so providers are turning away new referrals. 63% of them are discontinuing programs. A lot are considering additional program closure in addition to that 63%. And especially for consumers with intellectual and developmental disabilities, there are 51% on wait lists, and those wait lists continue to grow. They're not getting any shorter, and the delivery of care for folks on the wait list is something that's already challenging for many providers. So as a result, over 50% are now self-directing their care, or their family is self-directing their care. And we're seeing across the nation this shift toward compensating even family members for delivering care. And that's essentially to fill in the gap that providers are not able to cover on their own. This is creating a very unique situation here. And so we know that congregate care has really never been the answer, but it does persist. And I think the service, as a service strategy for populations of need across the nation, we really need to understand why. Why are we still doing institutions in some part of the country? Or why are we still embracing group homes when folks want to live with fewer and fewer roommates in more inclusive settings? And there are very specific reasons why. So let's talk about those and do kind of a breakout here for a barrier analysis related to why congregate care is still selected over in-home care. So this is really good context and sort of a foundation for understanding the need for technology, but it's essentially congregate care was developed and designed to remove some very specific and very tangible barriers. Most families actually still migrate to these service approaches when their loved one has complex needs, because they don't feel that those needs can be met adequately through home-based care delivery models. And that's because congregate care settings are easier to supervise. You're able to deploy support or manage it because you put a half a dozen people together, each with intermittent needs. You know that at some point there will be a need, even though we can't predict when. One of you will have that need, and then here's the caregiver to deploy to that moment. They also have lower ratios that are needed for care and are able to fill care gaps, staffing gaps, differently and better and more easily. So moving people into common spaces means you can reduce the number of staff in that space and get away with it more safely. There's also more attractive work schedules for congregate care settings. There's less part-time, there's better pay. Again, you're able to leverage those costs and those savings by congregating people. And it means that the direct care workers, especially who are new and have probably only been on the job for 90 days or sometimes less. You've got the new and inexperienced DSPs working with side by side, very experienced and tenured DSPs. And so there's a mentorship that's possible there and sort of a learning of the ropes, right? And the ability to get someone settled in and supported because there's somebody else who knows a little bit more. It's right at their fingertips. We're also seeing that clinical services are more cost-effective and accessible in congregate care settings. You can have lower housing and transportation costs. And essentially the jobs are able to be more specialized and simplified for meeting those complex needs. Again, because rather than it just being a one-to-one for the professional or the clinician, you've got one-to-many in conjunction with those boots on the ground DSPs. So with all of this stacked against us, what can we do to overcome the barriers and actually deliver in-home care that meets the vision of the final rule, but doesn't not address these barriers? Like we need to make sure that these gaps are filled adequately, or people will continue to choose congregate settings for their loved ones with complex needs.
You know, Megan, the reason we look at these barriers and assess them is because we need to know what people value. And we need to look at how we could deliver those advantages of congregate care. How could we differently deliver that in community settings?
Right. Yes, exactly. Beautifully said. Okay, so traditional service models may not be the answer, but they definitely still persist. They meet needs that ebb and flow. But they're highly intrusive. They're really overly structured, and they can be expensive to operate. Ultimately, they're really not designed for cultivating or preserving somebody's independence, especially, and it kind of goes back to that, like scheduling and meeting intermittent needs, things that are unpredictable, the needs that emerge around, typical life. That ebbs and flows. It's just really hard to deliver that on-demand need when your needs will be unpredictable or intermittent. Okay, let's see what's next here. So let's talk about what the solution is, and we're going to go and we're going to peek through the window at some other industries because we learn a lot from them. So. Spoiler alert, we think technology can really help overcome these barriers. And specifically when we can integrate technology into new and comprehensive human service models, we think that we will be able to advance all of the vision that's been outlined in the final rule. We'll be able to leverage costs and save money. We're going to be able to overcome those barriers we just talked about that are pervasive in traditional in-home or congregate care models. We're going to be able to improve the capacity and the stability of our direct support workforce and offer overall better service models, ones that support complete community inclusion. And the only way we can do this is with technology. So let's take a little lesson from Netflix. And Netflix is not the only one, but this is one of our favorite examples. Because what we want you to understand is that Netflix did not essentially take technology and use a service model like Blockbuster in order to deliver movies, right? We took the store that existed with Blockbuster, and Netflix instead was like, hold on a second, let's consider doing this differently. How else can we rapidly deploy movies on demand to the people who want to rent a movie? And if you remember, the way they started this was by mailing them to you. And this actually was preferred to going into the movie rental store. That was definitely made possible by a certain level of technology, but that also wasn't their end game. As technology has improved and evolved, which it does at a very rapid rate, they've been able to keep up and keep pace. And now we don't have to wait for snail mail to arrive with our movie in it. You can click into their app on your smart TV and stream on demand. So essentially what we want you to recognize is Blockbuster latching on to and holding on to that old traditional service model and thinking they could just bolt on technology in order to stay ahead of the curve. It was their doom, and you don't find very many Blockbusters anymore. In fact, I don't know if there's any in the country anymore. But Netflix isn't the only ones who did this, okay? Amazon did it, Instacart did it. Essentially, the intention here is, how do we get the products to the end users by not making them go to the store? And so let's tie that back to our industry, which is caregiving, but we've done it through the store. We've done it through a brick and mortar infrastructure for many, many years. And the reality is that infrastructure needs to be reimagined based on what technology can now do for us. We're not promoting or suggesting that you take what technology can do and bolt it onto those old service models. That'll get you a little ways, but we're talking about innovation and what the next generation of care is going to look like. And in order to do that, we really need to reimagine and rebuild the service models based on what technology can offer. So yes, it's all about logistics and rapid deployment. We want to avoid this question. Would you like to have virtual support or human support? You and I never are asked that question. In fact, really the question should be, how can virtual support technologies be used to deliver better human support? We don't want to take humans out of a human service model, but organically pushing forward self-direction, personal safety, lifestyle preferences, inclusivity, autonomy, independence, the ability to self-direct and do it all affordably really has to be imagined under the auspices and with what technology empowers. You can't have one really without the other. And so choosing either virtual support or human support, we would really like to avoid that. Anything to add there, Mike?
Well, it's just, every day, and including in this meeting, there are meetings that we have that we want to have in person because we don't know the person and maybe it's an important meeting,
Right.
Or there's times where it's more efficient to have it remotely. And that's just on one dimension, but the reality is we don't make these decisions once a year and put it in a person-centered support plan.
Exactly.
We do it organically as every need arises. I mean, literally, my day, everybody here's day, ebbs and flows back to virtual and in-person activities throughout the day, and even based on the context of the behavior. Every need should be an opportunity to make that decision, just like it is for us.
Right. And that's what we're doing here. I've chosen to turn on my camera and give you a little peek into this space in order for us to interact in a way that wouldn't be made possible without the technology that we have at our fingertips. I'm self-directing it, I'm choosing it, and it does have privacy controls built in, which we're going to talk about more. So really, when you imagine what technology-enabled community service models can do with technology, we can overcome the barriers for in-home care. We can deliver better support to our direct support professionals and caregivers. We can latch on intensive health or behavioral training supervision, clinical services. We can do all of that on demand, ideally provide remote and in-home support, either scheduled or deployed, so that the meeting of needs can revolve around those needs that ebb and flow unpredictably. We're also able to leverage families and help provider fill in these gaps of care. So essentially not making somebody trade their independence for more restrictive care settings. We can less intrusively detect needs and identify when care is needed. We can empower our direct support professionals to work full-time. Ultimately, when we put these things together, we're able to advance that self-direction, privacy, independence, autonomy, and essentially remove the complication for delivering that professional support in a non-congregate setting. So at a high level, I just want to share with you that really the problem with most independent living technologies is that they have not been well integrated into human service models. And they have not been delivered by individuals who know the person that they're serving very well. So while traditional human service models of care are really not designed to take full advantage of what technologies can offer, you also don't want to have a very simplified or independent and individualized process for every person served. We get into that like, oh, there's another app for that solution. And ultimately what that means is that providers are trying to bolt new technologies onto their unchanged and antiquated service models that have gotten us this far. But instead we need to be considering what changes to those service models are needed in order to really maximize what the technology can do, what's possible for delivering that vision of the final rule. So let's talk about the characteristics of a really strong technology partner. This is, I'm hoping at this point you're nodding along and saying, yes, I agree, I agree. So what do you need in order to engage with a vendor? The first one is to choose a platform. So something that's maximally scalable and infinitely configurable that meets individual needs. A lot of enabling technologies unfortunately put too much emphasis on the individual's desires or their person-centered support plan, but not really enough on creating solutions that are coordinatable and organized at the agency level. So we would advocate for the remote support technology to be considered a platform, an infrastructure, and a tool that's used on behalf of the organization to coordinate and personalize care, but that is ultimately organized in the background and put all together. So for example, you would never have each individual served choose their own electronic health record system. You have one that works for the entire agency. They don't really get a choice in that. But it is personalized and configured to meet their individualized need. Same thing for each employee. You wouldn't have them choose the HRIS system that we use to onboard the staff. That would be untenable. We really need we need these technologies working in the background in order to have agency-wide, largely coordinated supports in place. But we do need to make sure that that infrastructure can accommodate individual configurations and personalizations because of how important person-centered planning is, but not at the sacrifice of scalability.
Megan, I want to add a little to what you said there, because there's a science called implementation science. I mean, it's a thing. And it's all designed to ensure that the systems and supports that we have should be something that's scalable, replicable, and implementable, and can be implemented widely. And you have to understand that the people that are implementing this are in the context of, as we already know, a very high turnover industry. And so if you don't have a good system, I mean, this is why that example that you wouldn't have everybody pick their own EHR or their own video conferencing system within the agency. I mean, you standardize things so that you can get them implemented and widely used and scalable. But just because it's a standardized platform of technology does not mean, just like health records or things, that it's not that's not individualized. Right. Of course it is, and we'll explain how we do that. But I think in our field, you're seeing a lot of consumer-based technologies, and that's where you were talking about that app for that mentality. And by that is like, and in fact, if you remember, we were at a conference long ago where they highlighted, I think, 35 different technologies, and they claimed that there was well over 2,000, and they could, in fact, they didn't actually know the number. Of individual technology. And you can imagine if you take your iPhone out and you look at your apps and you start swiping left, you see not only apps, but folders of apps. If you can imagine that times 350 people that you might serve, what that would be like from the provider's end. How would you possibly manage that? How would you protect, private health information? How would you do any of those kinds of things? So the idea of a platform of remote and assistive living support, which is where the field needs to be, evolving, is really the only way that we're going to be able to deliver individualized services in scale to overcome the kind of barriers that we were talking about earlier of supporting staff and supporting people widely on demand.
100%. Excellent. So obviously that's sort of our first and most important characteristic for that we would recommend to you when looking for a technology provider to partner with. But we also wanted to sort of clarify that the functionality of the technology is also important. So looking for a partner that enables the technology to function the way a human would is really critical. We want to be able to see, hear, feel, and act on behalf of the individual served. And a common mistake kind of comes up in thinking that the hardware is the enemy of privacy, because you would never have a direct support, a professional DCW tie their hands behind their back or put on a blindfold before they walk into a home to support one another. So keeping somebody from being able to see, to assist, or to act on behalf of the individual when they request it, that needs to be a part of the platform, right? So that the remote support coach can has the eyes and the ears and the hands in order to help. So a good example of this that we have is so the advances in best practice and how they move forward once we know what technology can do. So you have on one hand open heart surgery. This was the only way to solve the leaky heart valve problem, but it's highly invasive. It involves cutting open the chest, working directly on the heart. It's a major operation. It's complex, requires very highly skilled surgeons, and the recovery time is super long until along came angioplasty. And what do you know? It's less invasive. It uses a very thin tube with a balloon, much smaller incisions. It's a much simpler procedure, which means it's way less complicated. And it does still require skilled doctors to perform it with specialized tools. But in the end, it's a quicker recovery, and patients often go home same day. So look, we're advancing with angioplasty, but if somebody were to come along and say, can't do the angioplasty because it's got a camera on the end of that tool. So sad to say, you're going to have to go back to open heart surgery. We would never do that. It doesn't make sense. So utilizing remote support technology with a camera, with a software, which I'm going to talk about next, is really, really critical in order to be able to do the least intrusive, but still very effective approach to care. So let's talk about this hardware-software combination. The next characteristic that I want you to focus on is, does it leverage software? So while we have on the one hand putting sort of undue emphasis on the hardware, what we really want to be looking at is the software that controls it. And this is where Mike was talking about it being infinitely customizable and personalized to the individual. But you consider your iPhone, this thing, right? Most of you have a phone, some sort of smartphone. And on your phone, you've got 4 cameras, you've got 17 sensors. And when you go in to buy an iPhone, you don't get to say, I'll just take 1 camera. Actually, no cameras, please, and only 2 out of the 17 sensors. But you do get to choose how the software interacts with those hardware functionalities and with those features in order to protect your privacy. And so what we're going to advocate for is that the technology solution you seek has the same ability to do that. This goes back to very, very important message. And that is, it's our federal mandate, it's our ethical responsibility to provide necessary and safe care in the least intrusive manner that's possible, that achieves the best and highest quality of life and the outcomes for the individuals served. So we've got this scale where we're essentially wanting to advance rights, but balancing care and intrusion. And our obligation essentially is to make sure that intrusiveness is balanced against the expected care outcomes, including self-direction and open access or equal access, the personal safety and privacy and autonomy that we were talking about. But recognize that those regulations and rights existed way before technology came onto the scene. They actually apply to every care strategy, all care strategies.
Including staffing, by the way.
Including staffing. There's no like free pass that you get because a free intrusion pass for traditional approaches.
But Megan, I'm going to point out here, the reason people have trouble with this
Mhm.
is because when you have standard practice, like in-home staffing is standard practice, it becomes accepted because there's no alternative to it. Just like angioplasty, when open heart surgery
Right.
didn't have angioplasty, there was nothing to compare open heart surgery to.
Right.
But and so when there's in-home staffing and that's all that existed, and there was nothing to compare it to, there really isn't an intrusion test because it's already deemed to be the appropriate method of care.
Right.
Then along comes something else.
Right.
And
Something.
then all of a
bigger.
sudden you have an obligation to compare it to.
Mhm.
And the most challenging thing in technology in our industry is they don't compare it to anything. They actually compare it to themselves, to itself.
Mhm.
So they're comparing, a remote support strategy to itself. They're not comparing it to in-home staffing.
Right.
If they did, then they have an obligation to see which of the two options that somebody might have would be the most private, least intrusive, which one is advancing privacy, advancing self-direction, advancing independence. And when you do that, you may find that there's one strategy that is superior to the other. So a superior strategy shouldn't have additional standards
Right.
on a less superior strategy. And that's where we are why we found ourselves in this space. We're not actually comparing it to the outcomes. We're just
Right.
comparing it. We're just
Right.
talking about the one strategy. We're not comparing it to another one. We're not comparing it to outcomes, but our obligation is to compare it to the outcome.
Yep. And to evaluate then how intrusive is congregate care compared to everything that technology makes possible. And our argument is it's always going to be considered more intrusive. And so putting all of those things together, the balance is really critical. So the fourth characteristic, and thank you, Mike, that was very, very well said. The fourth characteristic for choosing a technology partner is making sure that the software that's used is intelligent and capable of escalating matters, especially matters that are out of the norm. So you want to be searching for one that has software that's capable of acting intelligently on behalf of the individual. We like to give some examples here. So let's say Sam gets up in the middle of the night and he moves to the restroom and then moves back from the restroom into bed. And let's say that process takes 3 minutes, 5 minutes. That's probably fine. But what if it takes 10 minutes? What if he goes in the bathroom and stays in there for, I don't know, 20 minutes, 30 minutes? At some point, Sam and their loved ones are going to say, I think somebody should check on me. I think I would like somebody to make sure that I'm okay. Another good example, Terry goes in, turns on the stove, and then proceeds to another area of the home. There's really no activity in the kitchen for XYZ number of minutes or hours. At some point, there's a fire concern and safety issue that's going on there. And remember, since our goal is to deliver the least intrusive, potentially effective method of care, we want to make sure that the software for the remote support system is able to say, that's normal behavior, we don't need to intrude, or hey, something looks out of whack here, and we do need somebody to check in and to see what's going on. And this goes back to what Mike was saying before. There's no way to control what in-home caregivers see with their eyes or the actions that they'll take. But you can control that when you utilize specific optic technologies.
And I know you're going to get to that.
Yeah.
We can in a minute, but I want people to appreciate that all of this is done when we're talking about somebody going to the bathroom
Right.
at night and then staying there for 5 minutes and going back. And that's not an issue. But somebody going in staying for 20 or 30 or 40 or an hour becomes an issue at some point in time. You would know that either one of two ways. A staff person is in the home,
Right.
surveilling what's going on and,
Right.
and intruding in their lives, waiting for a need to address.
happen.
Or you have a sensor combined with software
Yes.
that's analyzing what's normal and what's not normal, and not reporting anything to anybody or invading anybody's privacy until something is filtered in as not normal.
Right.
So you got to compare, is it more private to have sensors and software in a home filtering out times where somebody doesn't need help and pinpointing times they do, advancing privacy?
Mm-hmm.
Or is it more private to have somebody in the home doing that?
Sitting there,
That you
waiting.
can't control, that you can't decide, what they see, what they don't see, what they do, what they don't do, what even the tolerance. You have no control over any of those factors. So the point I want to say is some people think that the presence of sensors in the home is an invasion of privacy, when in fact, if they're combined with software and they're factoring out times when people don't need help and pinpointing time when they do, and that those tolerances are actually decided by the person that's being served or their guardian. You're in a situation there where there's no case that you can make that would be somehow less private than somebody simply being in the home and doing that all manually. So it doesn't allow greater independence. It doesn't allow self-direction.
Right.
It doesn't allow, it really doesn't even assure personal safety.
Right.
So it's really important to know that we only figured that out by comparing one set of circumstances to the other, which is exactly what you're supposed to do when you determine intrusiveness.
Right. Yeah. And the sensors combined with that, the optic sensors, the motion sensors, essentially being able to deliver endless gradients of privacy based on the needs of the individual that are configurable for that home and for that person served. It's not what you're going to be able to get out of the staff who would otherwise have to be present to make sure that they are safe. So essentially, we know that there are certain camera technologies that will absolutely be advancing privacy. The camera is not our enemy. The hardware is not our enemy, but we do need to be very, very careful with how those things are implemented to make sure that the vision of the final rule and our regulatory sessions or requirements are met. Ultimately, self-directing the choice of service method for each need would always be the most preferred option in order to maximize that independence, autonomy, safety, and privacy. This is what Mike was saying before. And so one of the things we really want to share is that when somebody knows when and how to ask for help, their ability to live with greater independence and more privacy, it ramps up. And so it's very important to teach simple self-direction strategies and make sure that the home environment enables easy motions or easy actions for self-directing in order to deliver that immediate real-time access to folks who know and know the individual served and can help them problem solve and meet their needs on demand. So what we're looking to help you understand is that advancing privacy and self-direction is possible with sensor-based intelligence, personalized notifications and reminders, customized calling trees, and smart home automations. Those are going to be put together in ways that advance the privacy and self-direction more than traditional approaches can.
You really can't teach self. By the way, as a profession, I'm a behavioral analyst, so this is probably the most important thing for me is self-direction, because it is the most important skill that you can teach somebody to be more independent. But the reality is, there's no really effective way to teach somebody to actually really control their services unless they can ask for the right service to be delivered to them at the right time and have the choices of the type and kind of support that they want, and actually can support the configuration of their equipment, and it can support those sorts of things. But unless you do that and provide the remote support, they can't choose.
They can't choose, right?
They can't choose, and you're actually kind of cultivating a dependence.
Yes, you're cultivating dependence rather than independence. Well, and so for folks who really are maybe more on the side of need that is fairly independent, that's one thing. We also want to say, like, for the other end of the spectrum, for folks with really complex needs, in that case, we're looking for enabling the in-home caregivers to get the support that they need on demand. And this goes back to solving that barrier that we represented was causing folks to choose congregate care settings, because you have a novice DSP working alongside a tenured DSP, and they can help each other. And especially when needs are increasingly complex, home sizes are getting smaller and smaller, and individuals who are new on the job are being asked to care for people with increasingly complex needs, delivering them the caregiver, the support, and the on-demand training, the professional supervision or clinical support on demand becomes almost as valuable as it is on the other end of the spectrum for folks who are self-directing independents. So we're really looking at how you build, true equity and access for people with complex needs. It means being able to support their caregivers in the moment and place that their needs emerge as well. And I think there's a lot of best practice to be found here.
In small homes and small settings where
Right.
where it's almost incredibly challenging to provide supervision and mentoring and help when people need it.
Right.
So technology is obviously that solution for that.
Right. Okay, and then the last characteristic is a technology partner that really empowers remote support. And this goes back to sort of a concept again, and kind of a, like do not do. There's a big emphasis on monitoring and utilizing technology for surveillance and monitoring, which is not what we're not really what we're advocating for. Instead, we're wanting to, thanks to the software, have the ability to not watch. We don't watch. We want to make sure that the ability is, thanks to the software, being pulled forward for remote coaches based on the logic that we talked about before.
We advocate that, though, not just for technology, but we advocate that for staff.
Right.
That staff or its primary purpose can no more be monitoring or surveillance than remote technology can be for monitoring. Right. But it's, again, the same thing that has to be compared to each other.
Right. Right. So instead of focusing on monitoring, if we can focus on how to deliver remote support and do that with caregivers at the virtual level who know the individuals served, as well as the ones who deliver that support directly. In fact, they're the same people in our model. It's going to really set you up to win. And so delivering remote support is something Good Life has done for a really long time. It's something we're very proud of, but being able to walk you through the consents and the documentation, the MOUs that need to be in place, the signage, how you educate your stakeholders, all of those things really are part of implementing a next generation service model and the utilization of remote support. And so look for a partner who can really help you walk all the way through that implementation process.
Including stakeholder education, staff education, even public, leadership education on policies, procedures, funding, best practices, those sorts of things. Every state is unique and different and has different regulations. And I know we're going to talk about them, but regulations are created around existing technology,
Right.
not new technology. And
Right.
so every time you introduce something new, it requires people to first understand it, and then over time, create a pathway for things that are more appropriate to implement.
Right. Yeah, excellent. So those are the 5 characteristics. We want you to be able to imagine extending the capacity of your very limited caregiver and health professionals, all of the resources that you have at your fingertips in order to support people with complex needs and those caregivers in order to deliver better care. I think we've covered safety well enough. I'm going to include these slides in here if you want to read very carefully. Essentially, we want to make sure that safety is at the core, along with the privacy, the self-direction, and all of that. So let me introduce you to a case study. This is by way of sort of saying, okay, that's what we know we're going for, what we're after. I want to introduce you to iLink Technologies and Good Life's Neighborhood Network, which is actually, when put together, an award-winning combination and a new ecosystem of care. Now, we're going to actually dig in, and Mike and I are going to be at your state's annual conference this year. I think it's either in May or June. And so we're going to be there, and we're actually going to do a call out session, a breakout session related to the neighborhood network. So I'm not going to dig in like so much there, but I do want to like introduce it to you and help you understand how, when you pair the right remote support partner with this next generation mentality, there's really so much that's possible. So the characteristics of a new paradigm of care include affordable, high quality, individualized care in typical homes, okay, but at the moment of need. So not congregate settings, not intentional communities. We're looking at high quality neighborhoods in safe areas. Then you're going to see tenured and full-time, well-paid caregivers that work really attractive schedules. And the third characteristic is really, really good supervision and professional support for those caregivers. This is overall going to result in sort of a, like, something you didn't know was possible. So the neighborhood network is really redefining what's possible for living an enriched, safe, private, and independent life. And the way that it works, I'm going to walk you through the equation, as it were. But the way that it works is essentially by fusing virtual and in-home care. We're infusing that into a neighborhood. So we're staffing a neighborhood instead of a home. We're allowing the staffing resources to walk alongside virtual and remote support, and walk alongside natural families or volunteer supports in these safe neighborhoods in order to allow for need to be provided 24/7, needs to be provided for 24/7. And thanks to iLink, caregivers are really able to meet those individualized needs on demand, again, promoting that much greater independence for a much lower cost. I think I mentioned it's award-winning. Here's just a quick snapshot of the awards that the Neighborhood Network has won, including, and most recently, the 2020 ANCOR Moving Mountains Award for Best Practice in Workforce Development. When we dig into the value of the Neighborhood Network in our breakout session at your annual conference, it's really it'll be good for you to have had the workforce background and foundation along with this technology foundation, because both of those things come together in a really meaningful way for the direct support professionals and professional neighbors that live there. Okay, so what is the Neighborhood Network? You're like, okay, so it wins awards. What else? You know, like what is it all about? Essentially, here's the equation. So we take a well-selected neighborhood, we infuse that neighborhood with iLink Technologies, and also remote and direct support for the Neighborhood Network. So what we mean by a well-selected neighborhood is one that's safe, it's accessible, it's already close to existing community resources and amenities. Those amenities are really attractive, and they're already built to be inclusive and accessible. So we're selecting neighborhoods where aging adults already live often, and essentially leveraging public transportation or existing amenities to make the most of the individuals that we're going to have live there. And next we add technologies. So I'm going to introduce you to iLink. It's a technology infrastructure that really expands what's possible, saves money, empowers provider agencies to embrace the future of care. iLink has been kind of one of the best kept secrets, I think. It was actually started by Good Life in 1999, is the nation's first remote support technology company to actually be used to support people with disabilities in the nation. So the Neighborhood Network homes of the individuals supported are equipped with iLink, and I'm going to walk you through what that means next. And this is not a sales pitch, but I want you to understand how it functions really differently from what you might have heard about enabling technologies elsewhere, because this unique combination, you can't really accomplish one without the other. So iLink is essentially three things. We're taking a iLink Home, which is our hardware installation. This is, it's fully, let's see, do I have another slide? Yes, I'm going to go into that in a minute. Okay, so we have iLink Home, the hardware. We have iLink Assist, which is the software. And this is our proprietary intelligent cloud-based software that essentially allows for that remote support to be effective and affordable and secure, reducing intrusions, emphasizing and improving safety. And then we pair that with professional support on demand, using those remote support stations, even laptops, tablets, and smartphones to be able to empower support being delivered when in the right place and at the right time when it's needed. So iLink Home is a really, it's intended to be an extension of the professional care team. It can see, hear, talk, lend a helping hand. It really is intended to deliver that remote support when it's appropriate and effective to, it's essentially the extension of that caregiver into the home 24/7. Self-directing this unit is really critical. We're going to talk about the privacy and safety features of it in just a second, but essentially it's the press of a button indicates or initiates an immediate two-way conversation. Pretty soon that conversation will be video, not just audio, and it's to a hand-selected member of the person's care team. Uniquely, this can really start with whoever the individual served wants it to start with. So if it needs to go to a natural support or family member first, and then roll up to a neighborhood support person or a remote support individual, all of those things can be configured based on the needs of the individual. It's really sleek too. It looks really good. It's super easy to install. There's no behind the scenes or behind the wall like wires that have to be run anymore. It's all on a mesh network. And then there's iLink Assist. This is the software in a cloud platform. We have been creating and improving iLink Assist for 25 years. We remember that because we had to go through Y2K, right? We got real scared, I think, when when the year rolled over from 1999 to the year 2000. But essentially, iLink is created and developed intentionally to pinpoint issues that either do or in most cases do not need to be escalated. So when you have a very intelligent and easy to use smart home and it's equipped with half a dozen different sensors, those sensors are going to go off all the time. That's just data. That's just happening in the background. It's like popcorn. And it really just, there's no end to it, right? But once that data is interpreted by the software, this is really the ticket, because we want to make sure that we're not paying attention to every data mechanism that goes off in each home, but rather we're utilizing that intelligence built into the software to say, this is normal behavior, and no, this is not normal behavior. So what we're able to do then is tailor an alert system for rapid, immediate, and trusted response, and still have it be very engaging and respecting of privacy through the means of communication. Here's a quick snapshot of the technology or the software, the iLink Assist on the back end.
So just as an example on that software, if you have, first of all, we have set this so that the agencies can use this. It's kind of a teach the fish model where we help an agency learn how to use this, because we believe that every agency obviously knows the people they support the best. They know the regulatory environment. They know their policies and procedures.
Right.
But the way the software works is you just sign into it. It's a cloud-based software, so the remote support person is giving some authority to sign in, and it's what they see, how they can work with it is all determined by their permissions that are provided by the agency. And so it's an enterprise solution that allows people to sort of support people from anywhere based upon client permissions.
Yep. Beautiful. It's also got really infinite privacy controls built in. So from the direction of the individual served when it's appropriate, this has been built with the capability to allow users to turn the cameras on or off, or to be put into privacy mode, which essentially allows for other data essentially to be collected, not necessarily visual, but from the movement within that space. That can allow for support to be delivered, even though you can't identify and you wouldn't need to identify the person that's in there. So
we haven't really talked about this, but cameras can be incredible sensors. So even if they don't transmit an image, a camera can recognize who's there. They can also decide if you can recognize who's there, then you can have individual supports made and delivered for somebody. If Fred is in the kitchen, the rule for Fred is maybe different than the rules for Mary.
Right.
So knowing who is an important element, and there's different ways to know who other than cameras, but cameras can even as I'm seeing here today, people can control the cameras. I don't see anybody today. I did see somebody who changed their background. So you obviously can change what's seen, how it's seen, and cameras can also digitally black out any part of the home that you don't want to be seen, if that's the person's desire.
Which you cannot do with the staff that sit there. You can't stop them from looking down the hallway into the bathroom, for example.
Right.
But you
It's
can.
your obligation to compare it to that.
Yep. There's also this old school magnetized, what we call an eyelid. So just, in case you put like your thumb over your, right, or a slider over your camera, sometimes the really tangible solution is what feels best to folks. So again, when it's appropriate.
The light as well. The
indicator light.
Yeah.
Yep.
So the light is like a night light. It goes in any part of the house that you want. And it makes sure that there's a very clear, notice that there is no camera, or that's in privacy mode, or that's on. And again, the person can self-direct all of that.
Right.
Just like you guys are.
Yep. Okay, and then finally, with the neighborhood network, we're essentially infusing and leveraging different levels of care in order to maximize costs. Again, we want to keep humanity at the center of any human service model, and deep connection is what we need now more than ever. So on the very base layer, within a neighborhood network, we're able to leverage families and natural support network. This could be volunteers, it could be connections to your neighbors, it could be the individual's friends from church or what have you. But essentially layering that family and natural support as a first line of defense really allows us to optimize costs. The next layer is going to be the neighborhood care team. This is for folks who have maybe more intensive needs and are living in the neighborhood network. We're actually moving our direct support professionals into the neighborhoods as well. They are invested. They're next door neighbors. They live down the street or across the way, and having that neighborhood care team, who also provides the remote support, by the way. It's really critical because they are investing in one another and in their neighborhood. And the result is much more purposeful, intentional, socially active, and enriching lives. We're building communities, really special communities, but they're just in typical neighborhoods. They're it's I love my neighborhood. My neighbors are great. The folks who support me are great. My family is awesome. And then on top of that, we're able to leverage professional services. These are clinical or specialized services that are really they are not necessarily infused into the neighborhood, but they can be because of the remote system that exists there. So when a need sort of evolves beyond what a natural family support network or what a professional neighbor support network can provide, then we've got clinicians who are available, again, on demand, and can come right into the home to support the needs of the individuals that live there. So with a foundation of a remote support infrastructure, you really see that the applications are endless. The night support, remote health, the life coaching or memory support, service coordination, supervision training, and direct support professional support on demand, remote quality assurance, all of these things become a lot more accessible and possible because of the intentional infrastructure that's built into the agency. And iLink is really special that way. So we do a lot of work on, like I said at the beginning, the assessing and the evaluating and the improving of the system. And so I just wanted to give you a little insight into what the neighborhood network outcomes, how we're ranking, what the score is. And what you'll see really across the board is that we're seeing increased independence, reduced need for in-home staff. We're seeing that individuals who live in the neighborhood network have enhanced privacy. They know when and how to ask for help. They feel safer. They feel like they have a choice in their services, like they're engaged in their community and they're living satisfying and purposeful lives. And again, if you want to know more about the neighborhood network and sort of the special sauce, how we did it and what really went into the foundational I guess, philosophy that we use to build it, please come to our session at the conference, because we're really going to spend a whole hour on what this is, what it means for the individual served, for the staff people who work there, our professional neighbors, and for the agency.
And we'll bring the technology as well to
Yep.
have people experience it. I do want to point out
Yep.
that this review, this piece of research here, was actually done with a person served and independently with the University of Kansas, who was the group that actually gathered these data. So,
Right. Yeah, and half of the individuals surveyed actually came from natural families into the neighborhood network, and the other half came from group homes into the neighborhood network. So that gave a really good, I think, baseline for what's possible. Let's talk just really quickly about the policy regulations and funding implications of utilizing remote support. So essentially, necessity was the mother of good life's invention, and iLink really came about because there wasn't really an initiative in Kansas to make it a tech-first state. There are no funding allocations really designated specifically to the use of technology in Kansas. Every state looks a little bit different. But essentially what we know is that policy and regulations really have to be reconsidered and redesigned to promote the delivery of new service models that are leveraged by technology, and in order to meaningfully advance the care outcomes. So it goes back to what value-based essentially services are going to look like, and being able to leverage technology in those ways and in those services is going to be really critical.
the guiding, I do want to point out that the guiding principles behind policy and behind regulations really don't really need to change as much as how they're interpreted, because it does go back to the regulations always wrap around existing technology and existing best practice, and they sort of encodify best practice that they know of at the time. But when something new comes along, then it changes everything. For example, many states have quarter-hour billing, and so but face-to-face billing. Well, in truth, if face-to-face is more restrictive than remote support, then we need to be re-looking at that, and most states are already, definitely led by MCOs, are looking at that to rates that allow flexibility and certainly allow people to pick the least intrusive approach to care. So A lot of states have challenges with this. A lot of states have wrestled with what is the least intrusive, and they're experimenting with these sort of things. And the truth is, a lot of the technology is not is advancing so fast. As an example, Megan, we're heavily involved on the R&D side into beacon technology, wearable biometrics. The greatest loss of life is at night. People who sleep at night and who may die in their sleep when there is no support.
Right.
And biometrics, wearables, can notify people when you have too low of O2 or heart variations or other kinds of things can be notified, where we can then check on people. Those kinds of things are life-saving. I mean, we've never questioned whether we should have sensors for fire, right? Or carbon monoxide. I don't think we could even not have those sensors. But the reality is, other kinds of sensors that are life-saving are really necessary to get care out of our way and allow us to live the lives that we all want to lead. Are sort of just emerging at light speed. For example, the beacon technology, smart home technology, up until just recently, has been only smart at the home level. We knew that somebody was up, without cameras at least. We knew that somebody was up. We knew somebody left the apartment, or we knew somebody entered the apartment. We really never knew who unless we could look at a camera. Well, now with beacon technology, we're able to look at room presence of people, so we can have different rules for one person than another. And if I'm in front of a speaker, and it's time for my medication, and it knows that Mike Strauss is in front of that speaker, it can give me a personalized reminder that it wouldn't want to give to somebody else, right?
Right.
So technology is just advancing so fast right now, and some are so much better. And of course, then you've got AI, which then compares, current trends to baselines to deviations. It'll tell you, for example, there's one technology out there that is looking at deviations from normal for people who go to the bathroom too much. And it's a very high predictor of UTI infections, which is in senior citizens,
life-threatening,
one of the leading causes of death.
Yep.
So all these kinds of things are being emerging. And the customer, can live, even people with complex needs can live with greater independence because of these things.
Right.
So, the regulatory environment just has to grab a hold of that and understand, but the principle is the same.
Right.
Least intrusive, potentially effective approach to care that can accomplish the goal. It's the same thing. It was the same thing before technology. It's the same thing after technology. That's our obligation, but we have to compare. It's not compared to itself. It's compared to another option. So you have to compare what technology proposal is there to the alternative.
Right.
And
which in most cases is traditional care models, intrusive, congregate,
or other kinds of things.
Yep.
Sure.
Yep, absolutely. And this also reminds me what you were saying earlier about essentially the use of oh shoot, no, my train of thought. I'm afraid I missed it. I can't remember. Maybe it'll come back to me. But essentially, I think when we're talking about regulations, the intent here is to make sure. Oh, I do remember. It was about sort of unwittingly or unnecessarily empowering dependence instead of independence. And by looking at the policies and the regulations, and especially the funding mechanisms that are working against the ultimate goals of the final rule, there's sometimes there's going to be things that need to be modified, and comparing it to the alternative is the key, not comparing it to other
technologies. The
technologies.
final rule of the settings rule, by the way, as you know, it has multiple expectations of care.
Right.
Privacy is definitely one.
Privacy is one. Yeah.
But so is autonomy. So is choice and control.
Yep.
So is self-direction. So is personal safety. All of those things are care expectations, and really they're weighted. They're really weighted equally. There is no trump card of one over the other.
Right.
And they all are balanced with each other. So the reality is the approach to care that you must follow has to advance all of those the most
Right.
possible.
Right. Yep.
Not one, but all.
Right. So our goal overall should be to reduce the number of direct support hours. It's practical, it's affordable, it's pragmatic, and it's honestly so much related to the core of what we're trying to do in empowering strong communities and autonomous individuals to live in inclusive communities and home and community-based services. So with remote support, the number of those direct service hours can go down. Without it, though, the number of direct support hours goes up.
Let me say something before we're done about fractional care too.
Okay, yeah, that'd be great.
I'm sort of perseverating on nationally right now. I've been in states with Alaska. We just got back from Alaska, where 49% of the authorized hours are delivered, or Arkansas, where less than 50% of the actual authorized hours are delivered. The one of the greatest challenges is delivering fractional care to people in their own home. By that I mean, care that fills in the gap of need. And the problem is all the time that the care needs oftentimes can't be predicted. So
Right.
we're scheduling staff to be present when we think care might be there, but
Mhm.
maybe it's not present when it is needed. I'll give you my own parents who are no longer with us, but show them as an example. Between the two of them, in the last part of their life, they could meet probably 80 to 90% of the need, probably closer to 90% of the needs between them.
Mhm.
The problem was the 10% was intermittent, and they ended up having to trade 100% of their independent or 80% of their independence for 100% care in assisted living. And they could not afford it. Their life savings were gone. There were so many, there was so much devastation because they had to trade just the need to fill a gap of intermittent needs
Yep.
for continuous care.
Yep.
The reality is nobody wants to do that. No population wants to do that. And we can't afford it. And we don't have the direct support staff to do it.
Exactly.
So, and we have already become irrelevant as a country, as a providers.
Mhm.
When we can't deliver 50% of the need, I would tell you providers are now the minority. Self-direction, family-based support, or no support at all
Mhm.
for needs is the majority, and people literally are not getting their authorized hours. Authorized hours means what they need.
What they need. Mhm.
And that's what's driving people to more structured care settings that nobody wants or can't afford. So obviously we're in this really pivot moment. The needs are escalating. We can't supply them. We're getting farther and farther behind. Yet this is a solution, but we have to think differently about how we can deliver the care.
Perfectly said. And that just is the perfect transition into, I think this is close to the last slide. So what we want to help you, hope that you walk away with understanding is that technology does have a powerful influence on our lives, on your life, on my life, and it should be also a powerful influence on the lives of the people that we support. We can change the way that we do everyday things, and everyone has the ability to choose how technology can improve their lives. And they deserve that. They deserve having the ability to make that choice. Ultimately, technology-enabled services can absolutely deliver less intrusive support. And extending these benefits to the needs of the individuals who need them most is really critical. Ultimately, the goal here is building more inclusive and equitable care ecosystems and really getting into the grit of redefining how care delivery and service models can be designed based on what technology can offer that better empowers those really critical guiding principles that we talked about at the beginning: independence, community inclusion, autonomy, choice, self-direction, ultimately greater independence, right? So we we're taking a survey, and if you don't mind, get out your own cell phone that I know is nearby, your smartphone, take a picture, get out your camera and scan this QR code. We would love for you to take our survey. on, it's essentially intrusion and care practices utilizing remote support in order to weigh and evaluate the intrusiveness of those models. I'll leave this up for just a second. We are going to eventually, hopefully soon, be able to do a live poll in the session. But in the meantime, we're just trying to collect data from all across the nation on what you believe impacts intrusion and how that can sort of be recrafted or assessed based on what you heard today. So please take
Not
that.
just in care, but in your personal everyday life.
Exactly. Yep. Okay, and I'm going to send these slides so you can get this next time too. If you want to learn more about iLink, we would absolutely love to talk with you. Essentially, it's our mission to help educate on what technology can do to make better service models for people that we serve and the caregivers that make it possible. So don't hesitate to reach out if you want to talk more about it or share this presentation. We don't really hold back on who we teach or how we're able to connect, and we also learn along the way. So please don't hesitate to engage with us on that. You're also all invited to visit. If you're ever in the Kansas City area, please let us know. Sometimes seeing it live in action. We have 4 neighborhood networks, and it is so great. We want you to come and see how they work, how the individuals there are impacted on a day-to-day basis, and how their lives are improving and their independence is improving.
And this year we're expanding our neighborhood networks broader
Yep.
to include seniors. So, and roughly 20% of the population in the same neighborhoods are seniors who are aging in place. They all want to live there for as long as possible. So we're offering our supports in the same way to provide silo-free support, which is really, in my mind, the measure of true inclusion.
And true inclusion. Yeah, absolutely. Absolutely. And then, of course, please come and find us. We will have a booth at the association conference. Sorry, Marcy, is it in May or in June? Did I get that right?
It's in May. Yes.
It's in May. I got it right. Okay, good. Yeah, come find us. We're going to hold 2 separate breakout sessions digging into some of our best service models at Good Life, ones that we champion across the nation. And then, of course, we'll have some demonstrations at our booth related to iLink. Mike has a video blog and podcast where we really, I definitely encourage you to follow, like, subscribe, do all the right things to make sure that that's at the top of your podcast list. We drop episodes every 2 weeks, and this is it's conversational, intended to bring the experts from across the nation to the table with Mike to really talk about what innovation means in our industry and what strategies we can employ to make that possible. So he is the host and then co-host with Ivo Ivanov, who is terrific and famous in his own right. So definitely follow along there. And then, of course, if you have any questions, please don't hesitate to email me if you'd like additional information. We will send out the slide deck from today. So you can, sometimes my slides have so many words on them. Feel free to read that more carefully. If you'd like additional clarification or information, don't hesitate to email. I gave us 5 minutes for questions, sorry. Let's see what questions you have. We'll do what we can in the 5 minutes. I knew this was a lot to cover, so thank you so much for your attention. What would you like to talk about for 5 more minutes? Anybody have burning questions? We have Mike, our resident expert here, who can definitely help us with anything you'd like to know more about. Was there anything in the comments? Let's see.
I think one of the comments I saw was that potentially that your state doesn't allow certain things, and that's not, honestly, that's not uncommon.
Okay,
And
yeah, for the camera.
It's really just part of the process. We are in the middle of evolution of services on every dimension.
Mm-hmm.
So, these kinds of stakeholder discussions, education, and that's partly the surveys and all the work that we do is really designed to try to break through, where we are now to get to the next generation of care. And every time there's an evolution. I mean, I've actually been involved in closing 6 institutions. I think almost 18 ICF programs and development alternative programs. And then we've developed programs over the years, and then we've closed them and developed something else. I mean, honestly, our program has evolved, or we have helped other programs evolve. But every time that happens, you know, there is challenges to get to that next level of care, and we have to work together to do what's in the best interest of the people that we serve, and that's really the focus that we keep our eyes on. And one of the things we're doing, a fun one that we're developing right now, is the privacy paradox and the intrusion game, where we're literally spending a whole session doing forced pairs of different types of technologies and different types of things, and having people pick what's more or less intrusive, which one's advancing independence, trying to really actually grade them on those things so that we have, you know, practice in how we select, you know, the best approach to care for people. And I think we need practice in that.
Yeah, absolutely.
Well, that just sounds like you guys are doing so great to look at all of the issues involved in this. And that's what we want to look at too, is how we address capacity in our system and help our contractors. This is a newer realm. We have a little bit of technology in one of our waivers, but that's what we're looking is how we move forward. And of course, policy changes and things like that will go with it. But we just really appreciate you coming and presenting and telling us some of the options that are out there and being looked at, because
Absolutely. Happy to do it. We've learned a lot along the way as a provider, and yes, anything, hopefully you've at least walked away with some ideas and some framework for what to look for when asking next questions about technology, and we'd love to help in any way.
Thanks for letting us come.
Yeah, thank you. Thank you for letting us come.
we really appreciate it. Thanks so much.
All right. Be well, folks, until we see you in May. And yes, any other questions that you think of, feel free to email me. Okay.
Awesome.
Great.
Okay. Thanks so much.
Bye
Have
for
a good
now.
one. Okay.